Platelets are a very important component of our hemostasis mechanism. As we have discussed in our previous lecture, that was about the hemostatic disorders. We have discussed in detail about the hemostasis and the hemostatic disorders. Now, there are some other type of the platelet disorders that are either due to the increased destruction of the platelets or decreased production of the platelets, or there may be any functional defect in the platelet as well. That obviously will affect the platelet count. The patient who are suffering from the platelet disorders, they usually manifest with the acute onset of the bruising, the different mucocutaneous bleedings, gingival bleeding, epistaxis, menorrhagia, etc. Like Roger, if you have watched the case study of this lecture, then you must know that Roger is a 5-year-old boy who was suffering from acute onset of the bruising as well as the mucocutaneous bleeding, that is the bleeding in the mucosa of the oral cavity. Now, in this lecture, we are going to study about all of these platelet disorders where either the number of the platelet will decrease or increase, either thrombocytopenia or thrombocytosis. And we will try to find out the answer of our case study by going through all the disorders, by studying them one by one, their etiology, their clinical features, and the number of the platelet or the platelet count, and we will find out that what kind of the disorder Roger is suffering from. So for that purpose, let's start our lecture first with the main causes of platelet disorders. As I told you, either there can be decreased production, like there is some kind of the disorders in the stem cells, in the bone marrow, either there is bone marrow infection, either there is any malignant condition that is affecting the stem cell, and either the stem cell maturation is being affected, so there is decreased production of the platelet. Or there can be increased destruction of red blood cells, increased destruction of platelets. Like in case where there is the production of histocytes and where there is the production of the macrophages in the bone marrow, and that will obviously cause the phagocytosis and destruction of the platelets. And then there is a third type of a third cause that can lead to the platelet disorders, that is the impaired function. Now, platelet disorders can be because of all these three things: decreased production, increased destruction, or impaired function. If you talk about the normal platelet count, it is usually above 150,000 per microliter. In all the disorders, this level of the platelet will be decreased in the thrombocytopenia that we are going to discuss. Thrombocytopenia is actually the decrease in level of the platelet count, and thrombocytosis is increase in the platelet count. First, we will study about the thrombocytopenia, that is decrease in the platelet count, and at the end of this lecture, we'll also discuss about the increase in platelet count, that is the thrombocytosis. So first of all, let's get into the thrombocytopenia. Thrombocytopenia, as I told you, that it is a decrease in the number of the platelets. Normal platelets is above 150,000 per microliter. In case of the thrombocytopenia, the level of the platelet is less than 150,000 per microliter. Now, obviously, that can vary, and the patient who is suffering from thrombocytopenia, he or she has prolonged bleeding time, and the prothrombin time and PTT, they are usually normal. So there are different causes of thrombocytopenia, and the patient who have the platelet count, the mild decrease in the platelet count, they can be treated easily, and they are not at risk. But the patient where the platelet count is less than 10,000 per microliter, they are at very risk of the acute hemorrhage. There can be the spontaneous bleeding in those patients. So let's discuss about the different causes of the thrombocytopenia. Now, we have mentioned that thrombocytopenia is decrease in the platelet count. That decrease is due to the decrease in the production or increase in the destruction. Now, let's see what is the causes behind this increased destruction or the decreased production. First of all, let's discuss about the decreased production of the platelets. Basically, there can be the aplastic anemia. Now, aplastic anemia is the autoimmune type of the anemia where there is a decrease in the production of the RBCs and the blood cells. So it can be a reason for decreased production of the platelets as well. Then there can be the bone marrow infiltration. Bone marrow infiltration means that there is a presence of huge numbers of the macrophages and histocytes in the bone marrow. Now, histocytes, they are phagocytosis. Phagocytes, you can say that they are responsible for phagocytosis, and macrophages are also the killer cells. They will cause they will affect the bone marrow cells. They will cause the phagocytosis and killing of the bone marrow cells or the stem cells that will ultimately decrease the production of the platelets. Then there can be the bone marrow suppression by drugs or radiation. There are some drugs that are immunosuppressants like the corticosteroids and various other drugs like the drugs that are used to treat the hepatitis. They can be responsible for the bone marrow suppression and decrease in the production of the platelets. Then there can be the ineffective production. There is the production of the platelets, but it is ineffective, like in case of the megaloblastic anemia. Now, megaloblastic anemia is the type of the anemia where megaloblasts are formed, and megaloblasts are the red blood cells that are very huge in size. Then there can be the myelodysplasias. Myelodysplasias is the production of immature red blood cells or immature blood cells, and there is numerous immature cells that are produced in this kind of the disease, and obviously there is ineffective production. Then there can be the increased destruction of the platelets that can either be immunologic, or that can be immunologic means that there is any sort of autoimmune reaction, or there is some kind of the immune reaction that is responsible for the destruction of the these platelets. Like it can be idiopathic. The cause is mostly unknown, like in case of the idiopathic thrombocytopenic purpura. Then there can be the HIV, and drugs can be responsible for this. HIV is responsible for the increased destruction of the platelets because it can cause the infection of the bone marrow. And when it causes the infection of the bone marrow, obviously it can affect the production of the platelets. And the drugs that we use to treat the HIV, they can also suppress or destroy the platelets that are being produced. Then alloimmune means that a reaction that is due to the non-self antigens, but the antigens that are from the same species. I can exemplify this by you taking the example of the graft tissue. Graft rejection is basically a reaction of that is classified, or that come under the heading of the alloimmune reaction. So alloimmune reaction usually can be a reason for increased destruction. Then there can be the post-transfusion purpura. Post-transfusion purpura word is basically a word that describes the spot-like appearance on the skin that is due to the hemorrhage that is taking place beneath the skin. So post-transfusion purpura, where there is the destruction of the platelets, it can be due to the antibodies that are being produced, and after the transfusion of the blood, there is the positive negative blood matching cross reactions actually takes place that are responsible for the destruction of the platelet. All of these things we will discuss in coming slides when we will discuss about the post-transfusion purpura in detail. Then it can be neonatal. The neonatal reasons they will be also discussed in this section in this lecture. Neonatal reason, mostly they can be genetic. There can be some genetic and familial defects that can be responsible for the destruction of the platelets. Then there can be the non-immunologic causes that can be responsible for the increased destruction of red blood cells. Platelets. There can be DIC, TTP, and HUS. Now, TTP is the thrombotic thrombocytopenic purpura. HUS is the Hemolytic-Uremic Syndrome, and DIC is disseminated intravascular coagulation. All of these three disorders can lead to the thrombocytopenia, and we will discuss about these three in this lecture later. Then there can be vascular malformations that can lead to increased destruction. There can be some drugs that can be responsible for non-immunological destruction of the platelets. Another reason for the thrombocytopenia is the increased sequestration of that will obviously take place in the case of the splenomegaly. It will also be discussed in detail. Then there is the dilutional causes of the thrombocytopenia, that is during the blood and plasma transfusion that can take place. So these all are the different causes of the thrombocytopenia that can lead to a decrease in the platelet count. Now, the platelet count, as far as it is more than 1 lakh per microliter, it is usually not considered as an emergency. But as I told you, when it is less than 20,000 or less than 10,000, then there is an increase in the chance of acute bleeding, spontaneous hemorrhage. So it should be treated as an emergency, and it should be treated immediately. Like in the case of the Roger, our patient, he was suffering from a disease that caused thrombocytopenia, and the platelet count was less than 20,000. Now coming to another disorder of the platelets, that is the idiopathic thrombocytopenic purpura. So the name is indicating that the cause of this thrombocytopenic disease is unknown. There is thrombocytopenia, and purpura means the spotty appearance of the skin that is due to the spotty hemorrhage beneath the skin. So this idiopathic thrombocytopenic purpura is basically an autoimmune thrombocytopenia, autoimmune disease in which antibodies are produced against the platelets and megakaryocytes. So the platelets and megakaryocytes, they are taken as antigen, and against them the antibodies are produced that are then responsible for the destruction of these platelets and the megakaryocytes. Usually in this case, as it can be acute and it can be chronic as well. And in case of the acute cases, the platelet count is less than 20,000 per microliter. Now, just keep these points in mind that I am going to discuss here. Platelet count less than 20,000 per microliter. Then this diagram is telling you about the appearance of this idiopathic thrombocytic purpura. As I told you that there is the destruction of the platelets and the megakaryocyte, that is by the antibodies or autoantibodies that are being produced. There is the megakaryocytes that are seen when these histological slide or histological appearance is taken. Then moving on to clinical feature, or furthermore explaining the acute and chronic condition of idiopathic thrombocytopenic purpura. There are two kinds of this disease, acute one and the chronic one. Talking about the acute disease. In case of the acute idiopathic thrombocytopenic purpura, this is a disease, or this is a state of the disease that is more common in the children. First, it is more common in the children. The platelet count is less than 20,000 per microliter mostly, and it is mostly in continuation or after a viral infection. So we can say that virus is responsible for decrease in the thrombocytes or the platelets. What is thought or what is considered is that the virus is responsible for causing some changes in the platelets that will later on cause the destruction of the platelets. And the symptoms that may be associated with this acute idiopathic thrombocytopenic purpura is the condition can be asymptomatic in most of the cases. Like there is not a number of the symptoms will be seen in the patient. Rather, there can be sudden onset of the petechia, or bruising can occur, or there can be the purpura, intracranial hemorrhage can be there. So these are the few symptoms that can be associated with the acute disease. Now talking about the chronic one. Chronic, in case of the chronic condition that usually occur in the adults, it is associated with the platelet count that is usually up to 1 lakh per microliter. That is between the 10,000 to 1 lakh per microliter. And the signs and symptoms that can be seen are the epistaxis, that is the nose bleeding. There can be the menorrhagia, there can be ecchymosis, and there can be excessive bleeding after trauma and minor procedures. Now, this is the point where you can make the diagnosis of your case. What we have studied in the case that Roger, who is a 5-year-old boy, means that he is a child. There is severe onset of the bruising, and there is no other symptoms other than the bruising. There is no other history, there is no other clue. Side by side, there is the mucosal bleeding. There is no cause of the mucosal bleeding, there is no genetic history of the bleeding disorders as well. And moreover, if we took the complete platelet count of the Roger, that told us that platelet count is 26,000 per microliter. So we can say that there is a decrease in number of platelets. There is the new onset of the bruising or acute bruising is there. There is the mucosal bleeding is there. So couldn't you conclude that the Roger is suffering from idiopathic thrombocytopenic purpura? Yes, the Roger is suffering from idiopathic thrombocytopenic purpura. And you will treat your patient according to the treatment of this disease and this idiopathic thrombocytopenic purpura. In most of the cases, it resolves it is on, but whenever there is a condition, there is severe situation, then you have to treat this disease with the corticosteroids, as well as you will give the IV immunoglobulin that will be much effective in the treatment of this kind of the thrombocytopenia. So this is the answer to your case that you can made when you know about each and every platelet disorder in detail. Now, the next type of the platelet disorder is the drug-induced thrombocytopenia. When we were discussing about the causes of platelet disorders or the causes of the thrombocytopenia, we discussed that there are some drugs that are responsible for causing the thrombocytopenia. So the thrombocytopenia that is caused by the drugs is known as the drug-induced thrombocytopenia. There are so many drugs that are responsible for causing the drug-induced thrombocytopenia, like the quinidine, heparin, sulfonamides, gold salts, antibiotics, sedatives, tranquilizer, and anticonvulsants. These are the examples of the drugs that are responsible for causing the thrombocytopenia. Now, out of all of these drugs, you can say that heparin is a special case, or it is a distinctive one. The mechanism through which the heparin caused the thrombocytopenia, it is important. How? Let's discuss it here. Basically, the heparin, it binds with the platelet factor 4. This is the heparin, it will bind with the platelet factor 4. When it binds with the platelet factor 4, it forms a complex. Then this complex will bind with the anti-heparin or the platelet factor 4 immunoglobulins. IgG are being produced, or you can say due to the autoimmune reaction, IgG are being produced against this complex and these against the platelet factor 4, and these immunoglobulins will bind with this heparin and platelet factor 4 complex, and this whole complex will bind to this Fc receptor of the platelet. Now, when it will bind to the Fc receptor of the platelet, what will happen? It will cause very intense activation of the platelet. And when there will be the activation of the platelet, it will bind to the endothelial tissue, and as well as it will cause the aggregations of other platelets that will cause the formation of the thrombi. When there will be the platelet activation, there will be the positive feedback loop, platelet aggregation, and removal of the thrombosis. Now, that is in case of the in case when you stop taking the drug, that is the heparin. But when you are taking with the heparin, that may lead to the overactivation of the platelet, and that can lead to the formation of the thrombi. Now, explaining more about the heparin-induced thrombocytopenia, basically there are the two types of the heparin-induced thrombocytopenia, the type 1 and the type 2. This thing that we just have discussed, it is the type 2, where the immunity is involved. The type 1 is basically the type of the heparin-induced thrombocytopenia where immunity is not involved. That occurs usually 4 days after the heparin is taken. and that is very mild and it resolves on its own. But this the one that involves the immune system, basically it occurs after the 4 to 10 days that you have taken the heparin, and it is much severe as it leads to the formation of the thrombotic bodies or the thrombosis formation. So it should be treated as compared to the type 1. The next one is the pregnancy-associated thrombocytopenia. Now, the pregnant mother can also suffer from the thrombocytopenia that is usually in the third trimester. So, third trimester is the period where you can suspect that the mother is suffering from the thrombocytopenia, and this thrombocytopenia can be due to the various reasons like the preeclampsia and the eclampsia as well. The platelet count in the pregnant woman is usually more than 1 lakh per microliter, and that is the reason usually no treatment is given to the pregnant woman, because the level is sufficient enough and there is no risk of acute bleeding or spontaneous bleeding. HELLP syndrome or HELLP syndrome. This syndrome is also associated with the pregnancy-associated thrombocytopenia. As the name indicates, H stands for the hemolysis, EL stands for elevated liver enzyme, and LP stands for low platelet count. So in the pregnant women, this can also be a cause of the thrombocytopenia. Now, the neonatal thrombocytopenia. Neonatal thrombocytopenia, obviously, the thrombocytopenia that is present in the neonate, and it is basically, and mostly it is due to some genetic or inherited defect. Let's see what are the different causes that are responsible for causing the neonatal thrombocytopenia. Basically, there can be two reasons. Either it is inherited one or it is the acquired one. In case of the inherited, the thrombocytopenia, basically there are various defects, there are various genetic disorders that are the mainstay of this thrombocytopenia. There can be the Viscount-Eldridge syndrome that can be responsible for the neonatal thrombocytopenia, or there can be the amegakaryocytic thrombocytopenia. There can be the thrombocytopenia absent radius syndrome, and there can be Fanconi anemia and trisomy 13, 18, or 21. All of these disorders are associated with causing the thrombocytopenia. Now you can read the detail of these disorders in genetics as well. Basically, discussing them here is the main purpose of discussing them or mentioning them here is that there is genetic or familial cause of thrombocytopenia as well, and you should not neglect this cause when you are diagnosing your patient or when you are prescribing your patient who is suffering from the thrombocytopenia. But there can be other causes of thrombocytopenia, like the acquired one, there can be any disease or infection that can lead to the neonatal thrombocytopenia. Then another type of the platelet disorder, the thrombocytopenia, you can say, is the post-transfusion purpura. Now, post-transfusion purpura is basically more common in the women, because the pregnant woman, you can say. In the pregnant woman, it is more common or more, if we define, I define it more, it is more common in the pregnant women who are HPA1 negative. Now, the mother who is HPA1 negative, when he conceives a child who is HPA1 positive, obviously then there is a cross reaction takes place that then lead to the destruction of the platelets. Similarly, when a person who is HPA1 negative, when he receives a blood transfusion that consists of the platelets HPA1 positive, now, when the HPA1 positive platelets will enter in the body of the patient, the body will take them as an antigen, as a foreign substances, and the antibodies against those platelets will be produced, and there will be the sudden destruction of those HPA1 positive platelets. So this is caused as the post-transfusion purpura. In males, it is mostly due to the transfusion of HPA1 positive platelets, and that's why it is known as the post-transfusion purpura, the purpura that is seen after the transfusion of the blood. So that might be a reason when you are infusing the blood or platelet to your patient and still there is a decrease in the number of the platelets. Now, thrombotic thrombocytopenic purpura. Thrombotic thrombocytopenic purpura is basically another disorder that is that is a severe one, and there are the two forms of this disease: a thrombotic thrombocytopenic purpura and the hemolytic-uremic syndrome. Both of these are the conditions that are linked to each other, but the mechanism of both of these condition is much different. In thrombotic thrombocytopenia, let's see what happened. Basically, there is the formation of thrombosis, and this thrombosis will obviously, when in the capillaries or in the veins, it will block the flow of the blood, and there is the hypercoagulable state that can be achieved because of this thrombotic thrombocytopenic purpura. Now, look at this. This is a vessel wall to which the various platelets are attached. There is VWF factor, and there is the various other sites of the platelet. Activated platelets with one under the platelets are attached, and usually because of this attachment and reattachment, there is the formation of the multimers. Now, to maintain the normal blood flow, what happens that there is the multiprotease enzyme, that is ADAMTS, or multiprotease processor, that is ADMTS13. This is responsible for the breakdown of this multimer. In normal cases, what happens that this multimer into monomers, and there is the release of different platelets, and there is the normal flow of the blood, normal hemostasis is maintained. But in case of the diseased person, what happens that this metalloprotease is absent. That's why the multimers that are produced, they cannot be break down, they cannot be separated, and there is the formation of huge multimers that accumulates at the vessel walls. Now, when they accumulate at the vessel wall, they are responsible for formation of the thrombi, and they can block the vessels and they can lead to the hypercoagulable states. Now, what are the clinical features of this thrombotic thrombocytopenic purpura? It can lead to or it can cause the neurological symptoms, like there can be the seizures, focal weakness, aphasia that can be associated with the thrombotic thrombocytopenic purpura, or alteration in the consciousness. Then there can be the vaginal bleeding that can be associated. Obviously, there is this thrombocytopenia, the blood clotting, it is being affected. So there can be hemolytic anemia as well. The hemoglobin is basically lower than 6 gram per dl in this case, or the platelet count is less than 20,000 per microliter. And the jaundice is another feature that can be associated with the hemolytic anemia. Then there can be the renal dysfunction as well. There can be the proteinuria, there can be the hematuria, and mild renal insufficiency can be seen in the patients who are suffering from thrombotic thrombocytopenic purpura. Now, moving on to the pathology of thrombotic thrombocytopenic purpura. The periodic acid shift positive hyaline microthrombi are basically seen in the lining of the blood vessels, either capillaries, mostly capillaries, or the veins. Here you can appreciate this. Basically, these microthrombi that are formed, as I told you, they are because there is no destruction or separation of the multimers that are formed. We have discussed that in detail. For that reason, there are deposits in the capillary, they block the blood flow, and they can be easily seen on the histological slide when taken from the affected artery or capillary. Moreover, you can appreciate the RBC polychromasia, as well as numerous schistocytes can be seen in the specimen taken from the patient who is suffering from thrombotic thrombocytopenic purpura. Now, moving on to hemolytic-uremic syndrome. Now, as I told you when we started discussing the thrombotic thrombocytopenic purpura, that it is related to the hemolytic-uremic syndrome. Now, let me clear you that basically both of these are the thrombotic microangiopathies. Thrombotic microangiopathy is a broad term that covers both of these diseases and other diseases as well, but the main are the thrombotic thrombocytopenic purpura and the hemolytic-uremic syndrome. Though both of these are thrombotic microangiopathies, but the mechanism of both is different. Like in the previous one, we discussed that was because there is the metalloprotease is basically not present there, that is responsible for formation of the thrombi. But here what happens that there is the E. coli bacteria. Mostly in most of the cases there is the E. coli that is responsible for producing the toxins, or there is a Shiga-like toxin, verotoxin, that can lead to the formation or that can lead to the hemolytic-uremic syndrome that manifests as microangiopathic hemolytic anemia. There can be the thrombocytopenia, and there can be renal insufficiency as well. The rest of the symptoms that can be seen with this kind of the toxicity or this kind of the syndrome is the abdominal pain, bloody diarrhea can be seen, fever, seizures, lethargy can be seen in the patient who is suffering from hemolytic-uremic syndrome. Now again, this is a serious condition that should be treated immediately, and there is the thrombocytopenia also associated with this condition as well. Coming to our next topic, that is the splenic sequestration of the platelets. Now, when we say splenic sequestration, so the next term that comes to our mind is the splenomegaly. So what is the effect of splenomegaly on the production of the platelets? Let's just get into this. Now, liver is responsible for production of the thrombopoietin. Now, you must ask, what is thrombopoietin? Thrombopoietin is basically a hormone that is responsible for regulation of production of platelets. Basically, it affects production of the megakaryocytes and differentiation of the megakaryocytes as well. So in the liver, whenever there is a cirrhosis or any other disease, there is a reduced production of the thrombopoietin. That will then obviously lead to the splenomegaly as well, as we know that cirrhosis is always associated with the splenomegaly. So there is a decreased production of the thrombopoietin, and there is the splenomegaly as well. Now this splenomegaly, when there is a splenomegaly, that will lead to the splenic sequestration, and when there is a splenic sequestration, that will lead to the thrombocytopenia. Moreover, what will happen that there is a reduced secretion when there is a reduced production of the this thrombopoietin hormone. There is a reduced secretion of this hormone, and that will lead to a decrease in the level of the thrombopoietin in the blood. Now, when the level of the thrombopoietin is decreased, that will lead to decreased CMPL binding. Now, CMPL are basically the receptors to which the thrombopoietin bind, and that is then responsible for production and differentiation of the megakaryocytes. Now, binding is very decreased, and differentiation will be decreased as well. That will then lead to decrease in the platelet production. Megakaryocytes, they are not differentiated, platelets are not produced, and that will ultimately lead to the thrombocytopenia as well. So there are the dual causes of the thrombocytopenia. Splenic sequestration is taking place side by side. There is the no differentiation of the megakaryocyte that is leading to the thrombocytopenia. Moreover, the splenic sequestration can also lead to increased thrombopoietin binding and internalization, and that will lead to the degradation. And because of this degradation, further the level of the thrombopoietin will decrease in the blood, and further the production of the platelet will be decreased. So there is a decrease in the production of the platelet or destruction that is leading to the thrombocytopenia in the patient who are suffering from the splenomegaly or who are suffering from the cirrhosis. Now, there are some other causes of the thrombocytopenia as well, like there are some vascular malformations that can lead to the thrombocytopenia. There are the hemangiomas, and there are the atriovenous malformations that can lead to the thrombocytopenia. Hemangiomas basically can lead to the thrombocytopenia, and thrombocytopenia is very common in the patients who are suffering from hemorrhage or massive bleeding, like the patient who are suffering from the peptic ulcer and there is bleeding in the stomach maybe, or the patients who are going through the surgery and there is the massive bleeding during the surgical procedure. So these kind of the person or these kind of the patients, they can suffer from the thrombocytopenia as along with the other causes as well. Now, there can be the hereditary disorders of the platelets as well. Some of the hereditary disorders or some of the inherited causes of platelet disorders, we discussed that when we're discussing about the neonatal thrombocytopenia. Apart from that, there are some other defects that can be due to the hereditary causes, like there is the Bernard-Soulier syndrome. Basically, it is also known as the giant platelet syndrome. It is both qualitative and quantitative platelet defect, means that the platelet function as well as the platelet quantity is decreased in this kind of the syndrome or this kind of the disorders. What happen actually here, the glycoproteins that are responsible for binding of the platelet, there is a defect in those glycoprotein and platelet adhesion is affected, that then lead to the formation of the giant platelet, and that then affect the function of the platelets as well. Moreover, there is another hereditary disorder of the platelet that is known as the Glanzmann thrombasthenia. Glanzmann thrombasthenia, basically it is also a qualitative plus quantitative platelet defects. There is both the function of the platelet is affected as well as the quantity of the platelet is also decreased. There is the defect in the glycoproteins of the platelet, and the binding adhesion is normal. You can say adhesion is normal, but the function of the platelet is altered. And the patient who is suffering from the Glanzmann thrombasthenia, he will depict the symptoms of hemorrhage, bleeding, prolonged bleeding time, and menorrhagia, epistaxis, etc. And usually it occurs in the infants who are newborns before the age of the 10 months. Then there come the alpha storage pool diseases. This disease is also known as the gray platelet syndrome. Actually, what happens in this disease is that the alpha granules, they are deficient, and the platelet alpha granules are deficient, that lead to the alpha storage pool disease. Then in the delta storage pool disease, basically the dense granules are deficient, that lead to this delta storage pool disease. Now, the acquired qualitative platelet disorders, as we have discussed about the hereditary one. Now, there can be some acquired qualitative platelet disorders that will not affect the number of the platelets, but that will affect the function of the platelets. Like when we were discussing about the three types of the platelet disorders or the three main causes, we have discussed that either there is a decreased production, or there is increased destruction, or there can be the impaired function. We have discussed about the decreased production, we have discussed about the increased destruction. Now the disorders that can be, or the defects that can be due to the impaired functions of the platelet. There can be various reasons for this impaired function of the platelet, like there can be some drugs that can be a reason of impaired functions of the platelets. For example, let's start from the aspirin. What is the mechanism of action of aspirin? You guys know that aspirin is a COX inhibitor. Basically, when it inhibits the COX enzyme, that lead to the inhibition of the thromboxane A2. And what is thromboxane A2? Thromboxane A2 is very important in the binding of, in the formation of the blood clot, or in the proper functioning of the platelets, mainly the platelet aggregation is the point where thromboxane A2 is involved. So we can say that when thromboxane A2 is not produced, the platelet aggregation is affected, the function of the platelet is affected, that is, the blood clot will not form appropriately. Then there are some other drugs that inhibit the COX enzyme, like the NSAIDs and SAIDs, like the ibuprofen, like the indomethacins. All of these drugs, they inhibit the COX enzyme, and along with other parts, they also affect the thromboxane A2 level, and that might lead to the impaired function of the platelets. Moving on to antibiotics. Now, antibiotics can be a reason for the impaired function of the platelets, like mostly the beta-lactam antibodies, like the penicillin. They affect the functions of the platelets. And exemplifying more, ticlopidine is another drug that can be a reason for the impaired functions of the platelets. Then renal failure. Now, renal failure and the thrombocytopenia, or you can say that renal failure and the function of the platelet, both of these are affecting each other. Like whenever there is a decreased level of the platelet, whenever there is impaired functions of the platelet, what will happen? They will exacerbate the condition of the kidney. Like if the kidney is suffering from any kind of the disease, or kidney is compromised in any way, and there is the platelet defect, then platelet defect will make the condition of the kidney worse. Likewise, if there is any uremic syndrome or in the kidney, that will exacerbate the condition of the platelet disorder, or that will cause the defect in the platelet function. So both of the conditions are affecting each other. Then there can be the cardiopulmonary bypass. In case of the cardiopulmonary bypass, there are some surgical circuits are used that lead to the platelet dysfunction. Then there can be the hematological malignancies that can lead to the suppression of the platelets production, or that can affect that can produce the immature platelets, or that can alter the functions of the normal functions of the platelets. Thrombocytosis. Now, this is the term that is opposite to the thrombocytopenia. We have discussed about the thrombocytopenia, that was the decreased platelet count, and this thrombocytosis is basically the increase in the platelet number. Now, platelet disorders, that can be two types. Either they can be increased platelet or decreased platelet. Increase is the thrombocytosis and decrease is the thrombocytopenia. We categorize the various causes of the thrombocytopenia, and we discuss them one by one in detail. Now let's see what are the reasons behind this thrombocytosis. Basically, the thrombocytosis or increase in the platelet can be acute due to acute or chronic bleeding. There can be infectious disease, that can be a reason of thrombocytosis. There can be the splenectomy, that can be the reason of thrombocytosis. Any chronic inflammation can lead to thrombocytosis. There can be the use of glucocorticosteroids. There can be the fracture of large bone, the bone marrow is being affected. That can lead to the thrombocytosis. There can be any extensive surgery, or there can be some kind of the malignancy. There can be some kind of the oncological disease that can lead to the thrombocytosis. So these are all the reasons behind that can be a cause of the thrombocytosis and can increase the number of the platelets. Now, like the thrombocytopenia, this condition is also important, and it should be considered seriously whenever diagnosed and treated well. So this was all about our today's lecture, that was about the platelet disorders. In this lecture, we discussed in detail about the platelet disorders, including the thrombocytopenia and the thrombocytosis. First, we discussed about the thrombocytopenia, that might be due to the increased platelet destruction, decreased production, or impaired functions. We discussed in detail about the various causes of the thrombocytopenia, like that can be the idiopathic, that can be the immune-mediated or non-immune mediated, that can be due to the pregnancy in the neonates, like in the post-transfusional one, the dilutional one, and those that are due to the hereditary or the familial disorders, and also we discuss about the acquired one. Then we discuss about the thrombocytosis in detail. Now, concluding everything, we also answered our case study. The case study was that Roger, a boy whose history include the acute onset of the bruising, who's also he was suffering from the mucosal bleeding in the oral cavity, and there is no other sign and symptom he is suffering from. So the Roger also his CBC showed that the platelet count is 26,000 per microliter. So when we were studying about the different platelet disorder, we concluded that our patient Roger was suffering from idiopathic thrombocytopenic purpura, and we also said that we will simply treat our patient if there is a severe condition, then we will treat our patient with the corticosteroids and will treat it with the IV immunoglobulins. So that's how, when you know about the platelet disorder, you can easily diagnose your patient, and by knowing the cause and the clinical feature, you can go to the depth of the diagnosis. So this was all about this lecture. Thanks for watching sqadia.com.